Dr. Kalu, I'll start with you and the amazing work that you do. I admire who you are and how you engage your patients and how you really advocate for us to help, decrease inequities in healthcare. You've done so much, I mean, in your whole career, but you've done even since the pandemic, seeing your level of commitment you've put into all your work to change how we're getting equitable care. Can you share a bit about what you've been doing in the past few years in your career to help to change how we can get access to equitable healthcare as Black and Brown patients?
Sure. Good evening, everyone. My name is Dr. Kalu. I am a breast surgical oncologist, primarily in the Newark, New Jersey and metropolitan New York City area. And thank you, Maima, for such a wonderful introduction. So for the majority of my career, I've dedicated my time and efforts in improving the breast health education within minority population, particularly within African American and women who are part of the diaspora. What I found during my training, I found that a lot of younger women of color, particularly Black women, were being diagnosed at later stages with breast cancer. And of course, we know that young women are basically the backbone of families. These were young mothers, people in the prime of their lives, starting off their education and work careers. And this is something that I found interesting because prior to that, I really felt or really thought, mistakenly, that breast cancer was something for older patients, something more seen in communities of European communities or white women in this country, more so than women of color. So that prompted me to really direct my care, my research, as well as my future work goals and trying to promote breast health education within our community, because we all know that the basis of improvement within survivorship for breast cancer starts with education, starts with knowing your body and knowing your breast prior to your diagnosis. Since the pandemic, within the communities of Newark, New Jersey, and North Jersey as well, trying to improve patient engagement and patient health education with community fairs, engaging community leaders, as well as the city, to try and bring these educational platforms to the women and really to the community of Newark and the greater Newark community and Northern New Jersey. Because again, I felt it's very important for people to be educated on their health, for young women to know and learn about their breasts and be familiar with what is normal, so they will be quick to identify what is abnormal to try and achieve care at the earliest possible time.
Wonderful. For me, even, my mom taught me breast exams at 13 years old. And I always tell that story because she taught me that. That's why I knew my body enough to know before getting breast cancer that I had a lump in my breast. Mm-hmm. Many women don't know that they're at risk because they see a woman who's white or older and they think that's what breast cancer looks like, exactly. And not knowing that they're at a higher risk than that woman that they're seeing in the poster or in the advertisement. Wow. So in terms of your work, are you getting involved in education with? I know what you do. I know all that you're doing. But for those who don't know how fabulous you are and the work you're doing in the community, can you share a few programs you're working on to educate Black women about their risk factors and empower them in the community where you live and work?
Sure. So partnering with, like I said, a lot of the local communities, as well as local government, like council persons within the city, trying to organize educational platforms, educational conferences that are free to the community. And in conjunction with the local hospitals, with the local universities as well, bringing that education to the community in a fun activity sort of platform. So it's something that they could share with people within their family, all generations, from the very young to the very old. And then trying to incorporate that into something being more like either a bi-yearly or yearly event, something to look forward to. And also we try to extend into the hospital systems more of education or an idea towards implicit bias in the health realm. And the reason why I bring that up is because within the the idea of disparities. So we're talking about disparities of breast health among communities of colors compared to white communities. We see that part of it is it's multifactorial. It can be involved based on where a person is located versus their socioeconomic status, but also there's a level of implicit bias that we can't deny that exists in the healthcare profession. So on the physician's end, we try to start implicit bias programs and educational platforms for providers, so as to help to identify these things within our own systems. Because we truly don't know when we're coming into an environment or coming into a room, the inherent biases that we all sort of hold. Which is natural to us. We're human beings. We come in with certain experiences in life, and that's how we engage with other people or in situations that we encounter. So these programs that are being implemented in a lot of the medical systems, particularly in the Northeast, are helping to identify this within the physician and the patient care provider group. So that once we acknowledge these things amongst ourselves, we can start to make a change in the way we approach patients and trying to minimize that gap and disparities that we have identified in healthcare, particularly breast cancer care for patients of color.
I love that you're doing work that's bidirectional, reaching the patient where they in a way that's fun lifestyle with the family members, having that conversation with the moms, dads, where they are in the community. But you're also engaging physicians in terms of looking at the bias. And again, we all have biases, patients and providers, right?
Right.
So I think that, when you approach it from the doctor perspective to get them to know their bias, address it and overcome that bias, and the patients to be able to do the work with their family members and have the conversations that are tough to have or they're afraid to have, you're addressing both ends of the spectrum to build that bridge of trust between patient and provider. So how do you see the work you're doing to build a bridge, create more understanding and better patient outcomes when you can build that trust, transparency, and really work to transform the fear into being, fearless and knowing how to fight by yourself in healthcare?
Right. So it's made a huge difference and a huge impact because, first of all, as a clinician or physician, our first and primary job is to listen to the patient that comes into our office. So once we listen and hear the full story, we're able to have a better understanding of not only the diagnosis or how to diagnose the patient, but also how to care better for that patient, especially when it comes to cancer patients, because it's not only treating the cancer. Once a patient's diagnosed with cancer, that affects all aspects of his or her life. So it's not just their health, it's also their psychosocial balance within their family structure, and a lot of other things that come into play. So once you sit down and listen to the patient, you can have a better understanding of how best to treat the patient, not only from just a diagnostic perspective, but as in a sort of a holistic perspective. So we're trying to sort of address all facets of the cancer patient's issues. And after we acknowledge that, we may have, or we may come into an environment where there might be some unconscious bias, where you might make assumptions based on someone's background or what may or may not be of benefit for them in regards to not, standard of care, but maybe supportive care, maybe additional treatment options or choices that they should be offered. Once we eliminate that sort of barrier or that bias in your train of thought, you have a more open dialogue with the patient about what his or her options are. And once you have a more open dialogue and the patient is able to more engage actually in their treatment plan as well, I often see that patients do have better outcomes.
Fantastic. You're an amazing doctor. I wish they were all like you.
Oh,
I wish they listened, learned from us, leaned into us, because a lot of what I hear is that they didn't hear me, or they heard me and they didn't listen to me, or listen to me and they blew me off. And then just being able to see a doctor, look you in the eye, talk to you, respect you, honor you, and hold your life sacred, that can change your breast cancer journey and or your life outcome. And so thanks for all you do and how you how you provide a role model for many people, patients and providers alike, of what a good doctor should be like and look like, and engage with our patients and others. So thank you for all you do. You're amazing. And we know that you're such a rock star in the community for so many of us that are watching online, and those of us here on the panel today.
Thank you so much, Mayma. I appreciate you. And
You're
thank
welcome.
you guys so much.
We're glad to see you, learn from you, and to know you. I'm going to go to our angel advocates, Lachelle and Camille. I don't have my glasses on, so I can make sure I can see everybody properly. You are two of our amazing angel advocates at Tiger Lily, doing great work. And I've seen both of you transform, become even bolder, better, stronger, and just even in your own lives, different as you become more stronger in your advocacy. Can you tell me about why advocacy is so important to each of you, and then how it changed your life in terms of your breast cancer work and then your personal lives at home? And I'll start with Camille.
I became an advocate for several different reasons. I firmly believe that learning from the experiences of every Black, Brown, Indigenous woman of color can change the trajectory of health equity. I absolutely believe knowledge is power. And the Black breast cancer experience it's a unique experience. I'm glad for what Living with Breast Cancer is doing with Tiger Lily and this collaboration, helping everyone in the community, specifically becoming an advocate opened up a dialogue with me and my providers. So it wasn't so much of a monologue where in my treatment planning, they were telling me. It became a dialogue. Another very important thing that becoming an advocate did for me was it made my team respect me. They had to respect me because they knew that I was advocating for myself and my son as well. In order to humanize my experience with my providers. And I choose the word humanize because so often, historically, Black people are seen as less than human, especially in medical settings and how we're treated. So in order to humanize my experience, I would bring my, at the time, 13-year-old son to all of my appointments for that accountability piece. So that team knew you weren't just working for me, you're working for my son and his future too, because he needs me to be there. He needs me to be there at his graduation. They'd be like, oh, you brought your son today. I sure did, because we're kind of in this together. And it helped me. And I believe it helped the providers. It held them to a little bit higher accountability.
Standard?
Yes.
Of accountability, yeah.
Yes. And I would also ask them, are you a dog mom? Do you have pets? Do you have a partner? Are you married? And what does that look like for you? Because bottom line, what I really want in my shoes, what would you do? And I would give them direct eye contact, never breaking I'm looking at them. And that's just a few of the things that how advocacy affected my treatment with my team and in my medical community as well.
So that's really amazing. So being an advocate helped you to realize you and the doctor are on the same level. It's not because I think before I became an advocate, I thought, they're a doctor and I'm me, right? And I realized, no, the doctor is your partner in this work. They work with you and for you and took an oath to protect you. And so that when you can look them in the eye and ask questions and know that they're trusting you like you trust them and that you have a relationship, not a transactional interaction, it makes the whole experience a lot better because you're putting your life in that person's hands, right? And so and your partners in deciding what you will be doing with your treatment, radiation, chemotherapy, all of that. And I think it really emboldens you when you become an advocate to know how to really lead in your healthcare as well. Lachelle, what are your thoughts?
Well, I can just I agree with everything that Camille said. And just to piggyback, being an advocate, I was a community activist advocate before I became a breast cancer advocate. And for me, switching lanes, going in at the height of COVID, I was diagnosed, so I couldn't have anyone with me with my oncologist. I was kind of alone with this, and I had to kind of quote unquote learn on the job, as they say, and just kind of, okay, I'm trusting my doctor, but I'm not really sure. But I think she has my best interest, only to find out, becoming a Tiger Lily advocate and learning some things that I didn't know, that I didn't ask. And when I started to ask my first oncologist, hey, well, what about this? Hey, what about that? She became combative and thought I was trying to challenge her authority. And I was just kept saying, you know, I only have one life. I only got one me. So we got to get this right the first time. And I noticed that when the more I asked questions that I asked, the more her attitude changed. And she actually, the last time we saw each other, she left me in the room by myself for 30 minutes. And
did you fire her at some point?
I fired her. I remember I was almost complete with my Tiger Lily advocacy training, and we had a training that night. And I was really, really quiet. And they were like, well, what's wrong with Michelle? And I told them what happened. I broke down and cried because I couldn't believe that she had done that to me. So I started questioning every medical decision she made on my behalf, you know, for a year and a half. And now I have another oncologist, and now we have a great relationship. I ask plenty of questions, and I tell you, meeting Tiger Lily was the best thing for me. You may have saved my life, you know, because now I'm finding out things that my first oncologist should have did that she didn't do, but just taking this out to help other women like me, because also here in Texas, you know, we have the best medical facilities, but, you know, no Medicaid expansion. The breast cancer rate here is second after infant mortality. So no one was really talking about it. And so now I take my community activists and push it towards advocacy for breast cancer patients. And I share my story. I share everything from down to the bills that I get, so people can understand it's more than just the disease itself.
But they're treating a person that is in a body that has a soul, right? And they're holding your life in their hands. And I think that, you know, the healthcare providers have burdens, but the barriers that we're facing as Black women seems so insurmountable. And when you're being dismissed and blown off and left in a room, when you're feeling so vulnerable, it's not, I mean, we say that a lot, but it's something that can just really, like, it shakes your life, right, upside down. And it really makes me feel happy that you found a safe space to come and to talk to other Black women that look like you, because many of us have not had that before. But so having the space to go to really empower you to know what to do and how to work and fight for your own health and advocate for yourself. And it makes me sad that you went through that, but it makes me happy that you found a space to go to. I want every Black woman to have a place to go to know how to be her best advocate and have sisters beside her. And I'm so sorry that you went through that. But I can guarantee you that you're in this space now with all these Black women who are in the chat, who are watching, who are all rooting for you and Camille and Dr. Kalu and all of us in this breast cancer, people who on the chat who began their own nonprofits, that we're building a community that's will never let any of us be alone ever again. And that makes me really happy to see that kind of progress in our lifetime. I know we're running out of time. We began a little bit early. There are some technical difficulties, or technical opportunities, I should say. So I will skip two of the last questions, but I will ask you two, Lachelle and Camille, based on what you've learned and, you know, grown as an advocate, and, you know, maybe you were like a toddler advocate, now you're like a college student and you're badass and you're doing all these amazing things, for the patient who's getting diagnosed, who's not sure how to start to speak up with her doctor or use her voice in the community. What advice would you have for that patient, first of all, with her own self and her healthcare team, and then if she wants to help other women, and then go out and do community outreach as well? I'll start with Lachelle.
I would say take notes. I think I was overwhelmed at the time. And I know in many cases you can, you know, some facilities, you can bring another person with you. Also record your notes. I wish I had done those things as well. All I have to show is like a big giant binder that they gave me full of information and really no answers, but just you only have yourself in this fight, nobody else. So you gotta speak up and speak out.
Camille?
I have one thing that I want to share, and just a bit of advice is when you're facing this type of health challenge, you need to learn the language. You have to be able to communicate the language. I kind of made up my own Rosetta Stone style glossary, if you will, in order to really talk to them. And it made a huge difference, just learning the language, because Black breast cancer and breast cancer has its own very unique language. And in learning it, I was also educating my care providers to know the language as well, because a lot of them don't know. So we were both kind of learning together. Another just little piece of advice is that, again, speaking out as an advocate, because I think when we don't speak out as advocates, that we're just kind of like adding fuel to the inequity fire. Like it's already burning. And then when we don't say anything, we're just putting more fuel on it. We have to speak up because, I don't want to say anything. What these organizations are doing, Living with Breast Cancer and Beyond Breast Cancer, rather, and Tiger Lily is, that's putting out that health equity fire, because it's an absolute dumpster fire, I'm convinced. Let's see, any other advice? Also, I don't ask for health equity in treatment. I actually demand it. I have to demand it. And when I don't receive it and I'm treated as less than, I have to really question myself. Like, why am I loving myself this way? What broken part of me is saying it's okay to be treated that way? I would leave from various appointments. And if I felt some type of way, I would ask myself, this has to do more with me, because I'm allowing it, because I have a choice. I have a choice to sit here and not say anything. I have a choice to sign on the dotted line. I have choices. So in my journey, I've really had to take myself accountable to make sure that I'm loving on myself. So just love yourselves, and definitely know that you are not alone. We are all here together in a Black breast cancer revolution, quite frankly. And we are unstoppable.
All I see in the chat box are claps, hearts. Oh my God, yes, girl, get it. Oh my God, amazing, rocket. Like, you're just like, yes, this is amazing. I always say healthcare is the biggest way biggest self-care you can give yourself. Healthcare is self-care, and self-care is self-love. And so love yourself deeply and demand the best. Demand. Well, you all killed it. My heart is full hosting this conversation. Thank you, Dr. Kalu, Lachelle, and Camille. I love you all and admire you all deeply. And everybody who's watching, I'm sure, is so touched by your messages. They're inspired. And you all who are watching, you all are not alone. You have a sisterhood, a tribe that is on the screen and in the chat box that are here fighting for you, demanding quality care for you from the doctor's standpoint to the patient standpoint as advocates. And so thanks for having us. And thanks, Tia, for being an amazing host, having us host this today. And we're going to welcome Tia back to the virtual stage to kind of kick off the next panel.
Yes, Mayman, thank you so much. This was a great discussion. When I think about the work that we're doing and as patients, these conversations are so very much needed. And Mayman, if we can just jump to some of the Q&A, some of the audience members have questions for us.
Oh, I just saw the hearts and the prayer hands and all that. What are the questions?
I'll go ahead and read the questions for you. So I know earlier you talked about your mom teaching you about self-breast exams, and this is actually a question for Dr. Kalu. And the question is, since we know breast cancer risk is higher among Black women who often have lower access to care, what are your thoughts on self-breast exams? The American Cancer Society has recommendations against it, yet we know it can help. So Dr. Kalu, can you chime in on that?
Sure. I am and have always been a big proponent for self-breast exams. Just like Camille had said, first of all, Black breast cancer is different. And we have to treat it as such. We do know that Black women are diagnosed with breast cancer at an earlier age on average than white women. And sometimes that means being diagnosed outside of standard screening age. We know from the guidelines, American Cancer Society, we start breast cancer screening at age 40 with a mammogram and with a clinical breast exam by a provider. That provider is usually most likely your OBGYN or maybe your primary care physician. But we do know that particularly with Black women, upwards of about 15–20% of Black breast cancer diagnosis is for women who are premenopausal, and about 65% of those premenopausal are under the age of 40. So that means that they are outside of those standard guidelines for breast cancer screening. So of course, self-breast exam would be the only way for a young woman in particular, to identify any abnormalities in her breast. And also keep in mind that as a clinician, and research has shown that even in the most skillful hands, meaning most skillful physician who has examined a number of breasts, usually the smallest mass or tumor the most skillful physician can feel in size will be roughly about maybe 1 centimeter, 1 to 1.5 centimeters. And that's already putting a woman at a stage 1 disease. And usually when a woman who does not have any experience feeling a lump in her breast actually does feel that lump in the breast, it's usually something of a substantial size, over the size of 2 centimeters and beyond that. And that clinically is putting them at like a stage 2 or higher stage breast cancer, which is why I always feel that women of color, particularly Black women, once you start having your menstrual cycle, once you start having changes within your body, the introduction of a self-breast exam should be done. Usually that would be done probably by a pediatrician at that time, or with a young lady when she starts seeing an OBGYN. I believe a self-breast exam should be introduced. A proper one should be taught by a clinician. And as a woman, as a mother, you should advocate for your young daughters. And as a woman, advocate for yourself. If you fall outside of the so-called standard screening guidelines, and just say, look, I want to do a self-breast exam. Please teach me the proper way to do it, or send me to someone who can teach me if you yourself don't know how. Just like Camille had said, Camille and Lachelle, you have to demand the care that you deserve. Otherwise, the only person that suffers ultimately is you, because you're not getting the proper care and, frightfully may not be getting the proper diagnosis in a timely fashion. So in short, yes, I feel that as Black women, self-breast exams should start at a young age, preferably at the start of menstrual cycle, at least so you have familiarity with your breast starting at a young age. So you're quick to identify anything abnormal.
Thank you. Thank you so much. And Mayma, I'm going to pivot over to you. There was a question that popped up and people wanted to know, how can they become an advocate?
The Angel link is in the chat box. It's a really amazing program. We have a series of modules you can take. There's 15 modules, I think 4 are mandatory. We're going to launch a virtual program where you can go and take the program on your own time at some point as well, and do rapid trainings at events. So it's going to be 3 different ways. With the train the trainer in your own time, and then rapid training when we're at events. But it's really about community and knowing that you're not alone, and building a sisterhood as well. I think Ricky will say this when she speaks as well, Lachelle, we all know that. Tia, this when you first are diagnosed, you feel so alone. No one looks like you, whether it's your age, maybe stage or color or subtype. And within the program, we've had cousins meet who didn't know they even had a cousin that had breast cancer. We had people that met who didn't know that there was a neighbor that had breast cancer who was Black, and someone in their church. So it's just it's about education, empowerment, community, and knowing that you have the power of these amazing angel sisters behind you and beside you as you navigate your breast cancer journey. Yep. So yeah, so I love it. I know that it's our creation, but it's really about the community. It's not for me. I didn't have it when I was diagnosed. So I created it for all of you. And so please join. It's our website and then it's just go on the website and go into the programs page and then look for the Angel program. You can apply and then you're accepted. It's pretty easy and fun, and it'll fill your heart with love, joy, community, and sisterhood.
So we're going to talk about my favorite topic, clinical trials. And you guys know the numbers. You guys know what we're up against with Black breast cancer. And the only way we're going to get rid of these horrible statistics is to get better medicine and advance the science. So we need better science. So some of these docs are doing this work and are part of this, part of this important work that we all have to do here to get different treatments or more effective treatments for our breast cancer. So I'm going to start with my breastie, Latoya. What do you call me? She's my baby breastie. So what do you call me, girl?
You're my breastie mama.
A breastie mama. But Latoya is like our poster child for clinical trials. So what's your story, girl? Tell us your story. Share your story.
Well, good evening. Thank you, everyone, for having me here. I was diagnosed with stage 3C triple negative breast cancer at the age of 36 years old in July 2021. And I had a rough road with treatments and just, overcoming a lot of obstacles. But I was very adamant about being enrolled in a clinical trial. I very early on, I demanded that I was being part of clinical trials, and my oncologist at the time was not very open to the idea. But with my medical background, I knew that it was very important for my body to be studied and for me to receive the latest and greatest medication for my actual disease. And I had to fire my first oncologist, and I got another oncologist, and having to fight for immunotherapy and being part of a clinical trial that I was luckily to be enrolled in at a local academic institution. And when I enrolled into the clinical trial, I just knew, I felt it was like a sense of relief that immediately came over me, because I was fighting so hard to be in a trial. And the first person that I see who walks into the room, my principal investigator, is a woman who looks like me. And so it was like, okay, God, like, you sent me here. Like, this was ordained. I was fighting for a reason. And my reason, my why, is because it's very simple. I have 3 daughters. At the time I was diagnosed, there were 6, 4, and 1. They're very young. And I strongly feel like with any science project, right? You can't get to the solution if you don't study the problem, if you don't study why this is a problem. My body was a problem because there's breast cancer at a very young age without any known family history, without any positive genetic markers or whatnot. And I needed my body to be studied so that we can try to, get to a solution, so that when my daughters do develop breast cancer, I have given my children a fighting chance to try to prevent this disease happening to them. And so I was willing to do whatever to sacrifice my body so that it can be studied. I wanted my Black biology to be studied so that we can try to get to the finish line on, providing a solution. The clinical trial that I enrolled in is part of me building a medical trust fund for my children. It's no different from building, a custodial investment accounts or, a 529 college savings plan for your kids. This was, God gave me this disease for a reason, and I'm just going to continue to fight through. I'm going to continue to advocate. I'm going to continue to also serve my patients in the community, as a physician assistant. But I needed to do this for myself, but more importantly, I needed to do this for my 3 daughters.
Thank you, Latoya. And I love those words. She's building a medical trust fund for her 3 babies. Hello. And we all have to do that. Think of all the time, where we invest in our children as mothers, but knowing the state of her disease and our disease, we need more of those medical trust funds. We need more of that, protection and preparation for our babies. I work for my 3 grandkids. They're the same age as your babies, right? And so, they're my purpose every day. And I think we all have to, pay it forward, not only for us, but for our community, because we all need to do the work. So Dr. Sarah, can you share some of the work that you're doing and how you're helping kind of invest in science?
Definitely. Thank you first for having me here tonight. I love being on these panels, Ricky, Latoya. I love hearing your story too. And I'm so glad you're saying this to women, because I would love for all women to demand that their oncologist or doctor talk to them about clinical trials. So I'm a medical oncologist, as Ricky said, for over 20 years. I'm based in the DC area. I've been working in breast cancer and health disparities and clinical trials all of my career. Just very quickly, like Dr. Kalu, when I was in training, I did my fellowship at Georgetown here in DC, and a lot of clinical research was going on. That's where I developed my love for research. It was easy to get involved with trials. I did realize, though, that there weren't a lot of Black women that I was seeing, not only at Georgetown as patients, and this is back in the early 90s, but definitely not on the clinical trials. And so once I realized I had this passion for health disparities, I realized I couldn't even do research at Georgetown because to get enough Black female patients, I would have to go, actually there weren't enough for me to do a comparison. So, you know, kind of moving very quickly forward, I joined Howard University's Cancer Center in 2008, which was one of the best work experiences I ever had. I think that it's been commented on many times about the importance and the comfort and the trust of seeing someone who looks like you as your provider. And when I was at Howard, we had, I was a Black medical oncologist. The great Dr. Lori Wilson was our surgeon. The current president of the university, Wayne Frederick, was one of our surgeons. Our radiation oncologist, Dr. Jacqueline Dunmore Griffith, were Black. So the entire team was this wonderful group of really accomplished doctors, and we had patients, and our nurses were incredible too. And so all of this to say, you know, we just had a very cohesive, loving team working hard for our patients. But the one thing that was missing is that we weren't able to provide the clinical research the way that we wanted to. And one of the things that I learned at Howard, as opposed to when I worked at Georgetown, is that a lot of places don't have clinical research because they don't have the resources or the funding for it. And so even though you may want to provide clinical trials and research, you really have to have the infrastructure and the place that's willing to support that. So one of the other experiences I had when I was at Howard was that when pharma would come to us to participate in studies, and I'd say, oh, we would love to, because the other thing I learned is that my patients would say yes to be on a study if asked. You know, now we know that.
Yes.
But even back then, we, you know, they would ask, there was trust there, they trusted you as their provider. And so when I talked to pharma, I said, you know what, you know, we've got patients, they want to be in research, you know, can you provide some support for us to gather the data? You know, I had a half-time clinical research nurse. So she was there 2 days out of the week, and you really can't do a lot of studies without a nurse. So that's when I realized that there are a number of things that have to be in place. Of course, patients who want to be involved in clinical research, and we're getting the word out, and we know that our patients, especially Black patients, do, but also there has to be a commitment to support clinical research programs, not only at big universities, but also at community cancer centers, places where most people get their care. When I left Howard to go to the FDA to learn a little bit more about clinical trials, and while I was there, I also realized that the people who control where the clinical trials are, and that means the type of patients you're going to have on those clinical trials, are the pharma companies and the organizations that run the trials. And so we call that site selection. And so when I was at FDA, I was trying to figure out, okay, how can I make some movement on getting more involvement of minorities on studies? And that's when I ended up where I am now, which is working for an organization that runs several clinical trials, one of them a huge breast cancer neoadjuvant trial, but also a prevention study. And my job is to outreach and partner with advocacy groups. I work with, with MEMA and with Ricky more and many groups to try to make sure that we reach as many women and educate, like programs tonight, on the importance of clinical trials. And not only the importance of clinical trials, but also finding out what we need to do to support women who are interested in being on a clinical trial, and not only support women, finding out ways that we can support institutions that want to do clinical research that aren't able to. I think that right now, one of the most important things that we can do as Black women facing the potential of breast cancer in our lives is to make sure that we are getting the screening done the way that we should. I know Dr. Kalu mentioned that we know from science that as Black women, we tend to develop breast cancer at a younger age and more aggressive tumors. And the problem that we see now is that we have recommendations for screening for one size fits all, and we're not all the same. All of us are different. We all have different genetic makeups. Our risks for breast cancer is different, but we just don't know how to determine that. And so starting with clinical breast exams is one way that we can help identify, but there are luckily now some studies that are coming out that are looking at ways to develop the best recommendations for screening. And I work with one of those studies, which is called the Wisdom Study, and it's called Women Informed to Screen Depending on Your Measures of Risk. And I just wanted to talk about it for a minute because it's one of these unique studies that doesn't require you to go in to a place, which sometimes can be a barrier in and of itself for someone wanting to get on a study. It's a study that's 100% mobile, meaning that you can register, and the entire registration process you can do online or on your mobile device. But the beauty of it is that it not only takes into consideration the things that we have been using for years to determine a woman's risk, which is your family history and when you started your period, and a lot of that data that we have used to determine our screening guidelines has been from white women from many, many years ago. And we know as Black women that our breast cancer is different, and we need to be involved in the determination of the screening guidelines by being involved in the research that looks at why these breast cancers show up and how. And so the goal of the study is to make sure that Black women and all underrepresented populations are represented in this study, because this is what is going to inform the scientific community as to the best way to screen all women, including the number of Black women in this study. The beauty of the study now, which has been going on since 2016, is that in 2022, for one quarter, 16% of the women who enrolled were Black. And that's a huge number. And that was intentional because as this study was rolled out and women were enrolling, they started looking at the numbers and realized that only 1.7% were Black women. So it was the same story always, that we hear over and over, is that you have this great clinical trial that's going on that's going to give us this great information, but you look at the number of Black people involved and it is so small, you wonder, is this really representative of us? And so now part of the goal of the study, and part of, for me as a Black medical oncologist who works with breast cancer and recognizes how important this is to try to, to make sure that it reaches as many people as possible. And the study is unique in that it not only looks at your risk of breast cancer from the family history, but it also looks at your genetics and what we call personalized screening. And so you send in, if you choose to, a sample of sputum or spit, and they look for markers specifically from Black women who, along with everyone else, but markers that have been found that may be related to Black women who have increased risk. And they use that a lot. breast density to try to determine whether you're higher risk. And if you are, then they will recommend your screening to be not just yearly, but every 6 month MRI alternating with a mammogram. So that's, I know we're limited on time, and I know I could talk about this for hours, but the Wisdom study is just one way that I think that we are trying to include women of color in our research, so that when we talk about things like risks and we talk about how often you should get your mammogram, that we're talking about Black women as well. And we feel comfortable about that.
Yes, thank you, Sarah, so much here. And I know we have a lot of survivors and patients on the line here. And so I think this is something for our families. Like both of my daughters have now done the Wisdom study or joined the Wisdom study because our family has a risk because of me and my mom and my mom's aunt. So though we can't participate as survivors and patients, we can get our families engaged, which is so important to be able to have that science and build that database of science. So thank you for that. We had a comment in the chat, and maybe you can address this, Melanie, as you talk about that Black people are hesitant about trials because they haven't been proven, and you're doing amazing work at Georgetown to get the numbers up for Black women. Can you speak to that a little bit? And we're going to try.
And you said the question was that they haven't been proven?
Yes. The question was Black people are hesitant about trials that have not been proven.
I think, Ricky, I think you give a great example of this all the time. We take Advil, we take things that weren't previously proven. All of those things went through clinical trials. And again, doing some of the things that we are doing when we are facing breast cancer, chemotherapy, again, not always sure how effective it's going to be. So some of these things are seemingly trials, even though the science has been proven. So I think one thing is sometimes the narrative we hear a lot of times has to be changed. So we have to change the narrative in, terms of what we can learn from the trials and how it can benefit not only us personally, but us as a community. So I think that's one of the things. And again, I think the narrative sometimes is skewed about things that are and aren't proven, and where we get our information. We have to be very cautious and make sure that we're getting our information from reliable and trusted sources. Like I'm working with Lombardi Comprehensive Cancer Center, NCI designated comprehensive cancer center. So again, making sure that we're getting our information from those reputable places and having those conversations with trusted allies like the oncologists who've been on this call, et cetera, who can really help validate those things. I am Melanie. I'm a triple negative breast cancer survivor. I'm very happy to be here to be discussing clinical trials because I've been on both sides of the hospital bed. On November 21st, 2008, I was diagnosed with invasive ductal carcinoma. And in the weeks to follow, I learned that I had triple negative breast cancer, stage 1 triple negative breast cancer, which, as we know, is an aggressive subtype of breast cancer that disproportionately impacts Black women and doesn't have the same type of long-term treatments as some other subtypes. So I was a 38-year-old married mother of a 19-month-old and a 4-year-old. So I had to make some decisions, and my prognosis was very promising, but I was still very concerned because in my family, I had never seen many women who were diagnosed with breast cancer make it to 50. So I was very concerned about that. I worked with my medical team and decided to have a bilateral mastectomy, removal of my breast tissue, as well as a bilateral oophorectomy, removal of my ovaries and my fallopian tubes. I have a genetic a predisposition to breast cancer, and that also increases my risk for ovarian cancer. So I had to make those treatment decisions, as well as had 16 rounds of chemotherapy and reconstruction. And almost 15 years later, I am here to tell the story. So I'm very hopeful and very excited by that, but I also remain very troubled about our statistics. On a daily basis, I'm hearing stories either within my family or that I'm reading information that I'm seeing about our community and the way we are being impacted by breast cancer. And that is because, like everyone has said here, Black breast cancer is different. And one of the best ways that we can learn about it, manage it, treat it, really improve quality of life and length of life is through clinical trials. That's why I'm very passionate about it. And I also have my own personal experience with clinical trials. When I was diagnosed, I was offered the opportunity to be in a clinical trial. And while I was going through the decision-making process, I showed up at chemotherapy and learned that there had been some problems with some paperwork and some administrative details. And the option was either to delay me starting treatment or go ahead and start chemotherapy that day. And for someone who's young mother, I wanted to get started right away. So I wasn't able to participate in the trial. So that's why it's important to have both navigation and make sure enrollment and completion are all part of the process for having Black women involved in clinical trials. So again, as chair of the Lombardi Comprehensive Cancer Center Community Advisory Council, one of the projects that I'm working on is increasing awareness and participation in clinical trials. We know that representation matters and that knowledge is power. So if you're in the Washington, D.C. area, please make sure that you have my information so that we can share additional information about treatment, about clinical trials, and about options at Lombardi.
Great, and I put my email in the chat. I see a lot of conversation happening there. So thank you so much, Melanie, for all the work that you're doing, my bestie. So Dr. Vidal, how are you doing tonight? And I just have to brag on you a little bit, but he's doing amazing work in Memphis. And the numbers that you're getting to get Black women trials are just amazing. And I always ask you this, what's your secret sauce? What's making it work? And I know we work with you a little bit on our Nurse Navigator program, you know what we're up to. So what are you doing other than cooking these ladies dinner?
Thank you very much for inviting me onto this program. We've known each other for a little while now, and it's my pleasure to be part here. I think we're doing a lot of good, but mainly we're asking our patients to participate. The number one, there's data that suggests one of the number one reasons, well, one of the top reasons why women of color are not participating, or patients of color, is because they're not being asked. The physicians assume they wouldn't participate or assume the conversation is going to be difficult and time consuming, and so they don't ask. We at West understand our community. We understand that we're fortunate enough to have a large population of Black women. So that's one of our advantages of putting patients of color on study. But even if we do have a lot of Black women coming into our center, other similar centers don't do as well as us. We feel like once our patients come through the door, that they understand that clinical trial is an important part of your treatment here at West Cancer. So it's already something that they know we're going to ask them to participate. Then one of the things that I do and I encourage my physicians to do is to take the time. Navigation, Ms. Nix mentioned that. Very, 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 very important. Many times when I have patients who are hesitant, I have to take some time and have a second visit, or patients who's sitting in front of me and I've talked to them about a study and they're interested and go home and come back and say, my family members say no, then I have to take the time on my team to then reach out and say, can you bring your family member in so we can have a conversation? Because many times the misconception about what a trial is what's driving those decisions, and then we can get those corrected. So it is very, very important that you ask, that you spend the time, and that also you offer patient good trials. When we select our trials at West, we select our trial with our community in mind. We do understand, and I think you asked the question about why participate in a trial when it's a test. Is that, I think, I'm paraphrasing, but I think that's what the question was saying. First of all, a lot of patients who don't participate in trial but use herbal medicines, those have not been studied. And then we as a community feel that we place so much hope in those things. But two, designs of trials are a little bit different now. Trials are mainly designed based on what we call target, a biomarker. You have to have it so that you can get on the study. And what we know about biomarker-driven studies, they are more likely to be effective because we understand what's the root cause, and we're trying to match you to a drug that targets that particular cause. And the second, I would say, is there's often concern about getting a placebo.
Mm-hmm.
Trials, very, 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 very rarely do we have a trial that is placebo, but not standard of care. So generally what we have is standard of care plus placebo, or standard of care plus the treatment. Either way, you're getting what we would give you at minimum outside of a trial. So
there's no sugar pill in cancer research.
Yes, there's really no sugar pill, all right? And so once you have to correct those with patients and have more conversations with them, and that's why we at West, we put about 36% of our patients on study are of color, compared to about the 5% average around the nation. And we take it to heart, and we think that is a very, very, very important aspect of your management. So that's, in short, one of the reason for our success.
Right. I think also you talked about navigation and giving support and you supporting them. And, you know, we just launched our Nurse Navigator program. So when you go home and have dinner with your family, people can call us and get support and have like a fairy godmother breastie on the line. So, but I think it's also about the care that you're giving and how you're explaining the science to these women, and they're having better outcomes because of your care. So thank you so much for that. You're saving our lives.
And I will also add things like what you're doing, which, because we've worked in sort of in the clinical trial sector, advocating to the sponsors. Yeah. And I think Dr. Horton mentioned the sponsors are the ones responsible for selecting what sites, and going and advocating to the sponsors that you need to select your sites. Yes. And your studies need to represent the patients who are going to use the drug. Right. And also advocating that you have people of color at the table when those trials are being designed, because you don't know what you don't know. Right. And if you're not of color, you cannot speak for that that population of people. And so you're doing that a lot. And that's something that I try to do a lot of too.
Well, with your help, you know, and Mo, you're helping us so much. You know, we've now signed up 12,000 Black women for our clinical trial portals. And so we have much more work to do here. But Mo, bring us home, round us out, my partner in crime. And I know she's, because we've been working all day today. So.
But it's good work, isn't it? I mean, this is the work that we're placed here to do, and it's an honor to be here. Thank you so much, Living Beyond Breast Cancer, for inviting me. I'm Monique Gary. I'm a breast surgical oncologist in rural Pennsylvania. And, you know, when we talk about trials, there are barriers at every level, whether it is the interpersonal barrier of the physician who has bias and who's afraid to bring up a trial for that patient, who thinks that, you know, they're going to think I'm experimenting, or that I'm in cahoots, or that I'm going to violate the trust. Whether it's the part of the patient who's thinking, why are you bringing this up now? When I have all these things swirling in my head and there's so much going on, I can't think of one more thing. I can't think about this right now. Whether it's on the part of the cancer center that's saying, well, we don't have the resources to offer that trial here. Or whether it's on the part of the drug company that's saying, well, you know, here we are, we're trying to promote these things. And why aren't people taking up this life-saving opportunity? Like, there's so many places for miscommunication and for misunderstanding that is really important, I think, for us to have these conversations and to understand and to normalize that clinical trials need to be a part of our rubric. It's a part of our toolkit, not just at metastatic, not after the second line, third line, fourth line. Yeah, trials are great there, but there are trials for early stage breast cancer. There are surgical trials for innovation. The things that I do, you know, now, 5 years ago, we're in a trial. Those same surgeries where we used to take all the lymph nodes, we did a clinical trial, and now we can take 1 or 2 or 3. right? We're able to refine the medicine and make it so much better, make the treatments less toxic. And it's up to everybody in this entire cancer ecosystem to normalize this discussion about a trial. It's not a sort of hush hush. It's not an afterthought. It's not a pamphlet that you slide into the bag when you leave the office and you can read about it later on, but to have these open conversations and to hold everybody accountable for that. And so, you know, I know we got to get to questions in the chat, but I think that that's a real important thing for people to take home with them is to, if it didn't come up in your conversation, ask, hey, doc, what about a trial? Is there anything for me? And if that doctor says, oh, I don't know, well, can we look together? Right. And for that doctor who says, well, we offered it and, you know, and they kind of they didn't take us up on it, to revisit that conversation. Maybe they were overwhelmed. Maybe they needed some time to digest. Right. And for our pharma partners to really look at who's on the pamphlets, who's on the commercials, right? Where's the heartfelt? When you look at those commercials, the patient commercials, they bring you to tears, and the doctor commercials may cause blindness, may cause this, may cause this. Where's the heart? Where's the humanity? And reintroduce that into the conversation. And I think that we could all have a really great conversation. This time next year, hopefully we're having a really robust conversation about, look at the progress that we've made. You know, so I'm excited. I think the opportunities are there.
Well, yeah, Mo, and you hit on a great thing. You know, I every day I'm on, you know, talking to our pharma partners saying, you know, your baby's kind of ugly right now, but we can help you. And, you know, use the right language, use the right pictures, explain it in the right way. And we have to demand that. And we're so happy to help anyone understand a trial. And Dr. Vidal, you've referred to it, you know, you may have talked to the patient about it and then they go home and their mama says, no, honey, you're going to get the sugar pill. So that's what we do too. We'll, you know, bring your mama on the phone. We'll help explain the science to them and say, you know, that heart medicine I gave my dog Harper was in a clinical trial. And pretty much, I mean, you know, who got the new iPhone? Who got the iPhone 15? You think that wasn't in a clinical trial, right? Right. And Melanie can attribute, you know, even confess that I've done several trials as a survivor at Georgetown, measuring stress, measuring chemicals on my body. And so you don't even have to be doing a treatment trial. There's all kinds of science to participate in. And we need all the science. We need all the science. We need for Black bodies to be represented in all the science. And so we owe it to ourselves, our families, our communities, that, and we have to demand it from these doctors that don't always treat others how they want to be treated. So we have to demand it. So I guess we should go to questions, Hatia.
Yes, absolutely. So we have a lot of questions that's coming through the chat. So this was a very fruitful conversation. So one of the questions that many people have asked is, it's around, when should we be asking for a clinical trial? Like, is it too late to ask for a clinical trial? Do we need to be at a particular stage when we should be asking? So Ricky, if you want to pivot that question over to one of your panelists.
Sure. Well, I say any stage, but I'll pivot that over to Dr. Vidal. What do you think, Doc? Any stage?
Agreed. Any stage. We have very early clinical trials. Somebody mentioned, I think Ms. Johnson mentioned being in an early clinical trial and getting immunotherapy. Now, those trials, immunotherapy is now a standard of care for triple-negative breast cancer in the early setting. Those were trials that you could participate in. We have trials for drugs like T-DXd that is revolutionizing the way we treat metastatic breast cancer that now is up in the early setting. Any stage, even patients who are survivors. As you were mentioning, Ricky, there are trials that you can participate in. The whole focus and understanding is, one, bringing new therapies up front so that you can pay it forward to the next generation, getting the therapies for tomorrow today, and also having, by your participation, we're better able to understand how people like you with your biology respond to these therapies, both in terms of tumor shrinkage or cure rates, but also adverse events. Because we all end up using the drug anyway. But what we don't have is enough of us participating such that we can actually look separately at our group and say, this is how our group are participating compared to the other one. So at any stage.
Any stage. And, you know, I had, I didn't do a trial when I was sick, but when my cancer, my triple negative came back, I went on carboplatin, which at the time was experimental for TNBC. And now it's standard of care, as our video with Karen showed early on. You know, I was able to help the science and save my life. So today is my 12-year life anniversary. So when we get off the Zoom, I'm going to go eat a lot of ice cream and dance. But we have to do this work. We really owe it to ourselves, to our community. And I work for my 3 grandbabies. They're 2, 4, and 6. And so we have to make it better for them and for Latoya's kids, and do this important work and save ourselves. And also, Dr. Vidal, you made a good point that, right now we don't have very many therapies for TNBC. And one of the best therapies we have is for metastatic. And so now we're seeing the trials for testing those drugs that have been effective on metastatic and early stage TNBC. And we need those drugs. We need them now. And so we can't wait for anymore.
Thank you.
Totally agree.
Yes. So we have another question in the chat, and this has actually been asked about multiple people, and it has to do with the denial of clinical trials. When people are interested in participating in clinical trials, whether it's an age factor, whether it's comorbidities, can you talk to us and explain, why are we being denied for some of these clinical trials?
Anybody want to address that?
Dr. Horton, you want to take that?
Yes, you see, I'm like,
I know.
So, yeah, that's a great question. And there are a lot of reasons. Some of them, and I'll use the term legitimate, and I mean that by there are reasons, clinical reasons why a person may not be able to be in a clinical trial. And one of the things is we call it eligibility criteria. And that's kind of a complicated word. It just means that to be in a clinical trial, you have to have certain things in place. And one of them is they really try to have people otherwise as healthy as possible, meaning they try not to have a patient that has heart problems or kidney problems or, bad high blood pressure or diabetes that's not controlled. And sometimes that's not practical. But because the criteria to get into a clinical trial can be tough, and it can make it so that you as a patient, if you have other medical problems, may not be a candidate or be eligible. So that's kind of what we call legitimate, meaning that, when you look at the clinical trial, you have to have these things in place to be on it, and you may not qualify. When I was at FDA, one of the things that we were looking at was making sure that that criteria isn't too tight. Do we really have to make, not allow someone who has a little bit of kidney disease? Does that really affect how this drug is going to work? And we found that we could, in some situations, loosen up criteria and still have a very safe and effective study. It used to be that we wouldn't allow anyone who had brain metastases on clinical trials. And that, that excluded a lot of women, especially in breast cancer, where before, in the HER2 era, before Herceptin, we knew that, or once Herceptin started, we would get these women who would just have like one brain metastases. It would be treated and they'd have just minimal disease, and they might be a great candidate otherwise for the study, but because they had that one area in the brain, never could they be on the study. So now we know we've changed things so that you could be on the study if the brain metastases has been treated and it's stable or it's not growing. So it's evolving in terms of being allowed to be on a trial based on your medical qualifications. But then there are what I call non-legitimate reasons, people who aren't asked to be on the study because the doctors just aren't interested in research. They're just seeing the patients, because to talk about a clinical trial takes time. And as we, Dr. Vidal knows, and all the clinicians, and, Dr. Mo, when you're in the office and there's pressures from all sides to see patients, see them, in less time than we ever have, and to go on to the next thing. But to run a clinical study, you have to be able to talk to the patient, be able to spend the time so that they understand. And running a clinical trial is not cheap. It takes money. And a lot of institutions don't want to use that money to run a study if they're not making that money back. So there's kind of a lot of reasons why, if you're just looking at it from a business standpoint, running clinical research is not necessarily a financially smart thing. It's a very ethically and scientifically important and good thing to do. But if you don't have the financial support as well as the administrative support to do it, many places just won't do it. And if they don't do clinical research, your doctor's not going to want to send you away from them to a place that does it. So you may not be asked because your doctor may not just have access to clinical trials.
But no is never the answer. It's always how, and we will help you do it. We're working on a trial right now with a company where they do accept brain mets, and we challenge that all the time. We challenge all the trials with pharma, and we've been really aggressive about saying, hold on, a lot of Black people have high blood pressure and diabetes. You cannot design your trial by excluding those things. And so we're making those conversations happen. And I don't know, how much power we have there, but we really are challenging all the things that go into how we talk about it, how we explain it. And, I always say no is never the answer. It's how. Let's figure it out. Let's figure out how we can help you and advance the science and also, save some lives. So.
Ricky, I'll jump in and just say really quickly that it matters, because when you look at who are the people that have the most comorbidities, right? Who are the people that are most likely to be excluded from the trial? There's another level of disparity and inequity that we see. And so number one, it speaks to the importance of us as a people to really elevate not only our health literacy, but our preventive practices, right? And two, we got to generate more of what we call that real world data, because if you design a drug in a bubble and then you put it into a real world population and you wonder why it doesn't work and why there are all these side effects, it's because you never really tested it in that target demographic of those people who had hypertension and diabetes and kidney disease and all those other things. And so I think, science is beginning to realize and recognize the need for more of that real world. What happens when we put it into the people who are going to be receiving it and testing it in those individuals? And that I think is going to yield some really important scientific advancement.
Right.
And I will add to that, we have now different sort of trial designs. So we're talking a lot more about pragmatic designs that would allow you to design those trials in a real world environment, instead of having the trial be done in the sterile environment and then going back to try to see how patients are now doing. You design the trial up front without all of this exclusionary criteria, because that's when it's going to be used. And so those trials are now being designed, and we'll see more and more of them in the future.
Right. And Ricky can help you,
Yeah. And Ricky, I want to say, based on the conversation that we're having now, and I know time is running short for us, but I want to ask two very important questions that are actually coming from the chat. One is, there are a lot of people that are saying, hey, I have this health condition, that health condition. How can I find out about certain trials? So that will be the first question. Where can they go? And the second question is, what can we do as advocates to address this and help others when it comes to clinical trials and make an impact for clinical trial participation?
So to your first question, we have 3 portals on whenwetrial.org, and I'll put that in the chat. whenwetrial.org, that will take you into trial portals. We have our nurse navigator that will help you find a trial. And we have a lot of doctor friends who I call all the time and text and say, can you help us out? So I thank you for my friends here on the Zoom, but we will help people do it. I put my email address in the chat. I can't promise anything, and I'm not a doctor, but I just play one on Facebook, right? but with Mo, but we are so passionate about making the science happen by any means necessary. So if you're interested in a trial, we will do our best to help you figure out what questions to ask your doctor and how to demand the care that you deserve. I think in terms of advocacy, our web, whenwetrial.org, if you go to whenwetrial.org and go to the video gallery, you're going to see a bunch more videos like you saw with Karen Peterson at the beginning of the hour, and use them, show them to your friends, show them to other breasties, because I think that breastie love and hearing the voice of a breastie talk about their personal experience. You can hear Sheila Johnson talk, you can hear Ariana Apodaca talk, she was 19 with triple negative, and we try to make, refresh those stories. You can hear LaToya talk, and and talk about their experiences. And if you share them with other women, they're gonna, they're gonna feel it, and they're gonna feel the passion and what these women are expressing in terms of their stories to help convince others. And we're happy to help you if you need help with advocacy. We have plenty of materials. We have, we have lots of swag to wear, so we have lots of earrings. So we can help you out to talk about when we trial.
And we have a hand raised from Dr. Horton. If you want to jump in, Dr. Horton.
Just really quickly, I know a couple people have asked about clinical trials, and I know Ricky's When We Trial is a major resource for patients. Also wanted to put a plug for breastcancertrials.org, which is a free clinical matching software, web-based site where people could go, and it was written for patients. So it's like the alternative to clinicaltrials.gov for patients that is a little bit easier to use, but includes all of those clinical trials within their
yeah, and that is one of our portals on whenwetrial.org. So if you go to whenwetrial.org, we have breastcancertrials.org, we have the MBC Alliance, and we have a portal for triple negative breast cancer. We're also now building our own portal that should be ready by SABCS so that we can kind of help people go through the process. We will help people go into the portals and look for a trial. So we're happy to do whatever we can to help you do the science.
And if you're in the Memphis area and you go to the West Cancer Center site, we do have a clinical trial link that has all the list of our trials on there based on your disease. So.
Awesome. Well, we have more questions coming into the chat, and unfortunately we've run out of time. And we just want to say we're just so grateful and thankful for this conversation. And Ricky, if you can please place your information into the chat so that some of the ladies can actually follow up with you to get assistance on clinical trials. Well, thank you again. I just want to say thank you so much to our speakers tonight for sharing their expertise, their experience, and having these important conversations. And I also want to say thanks to all of you for joining us this evening and asking for great questions. And we do want to apologize. We did get started late. We had some technical difficulties, but thank you so much for being patient and sticking it out to hear these great conversations that we had tonight. Also, a quick shout out to our KIP Watch Party awardees, Sisters Can Survive, My Sister's Keeper, the National Coalition of 100 Black Women, Sister to Sister Alliance, and Touch for Life. I want to thank you again to our sponsors today for their support. I also want to thank our Black Breast Cancer Advisory Council for their hard work. We'll see you next week on Thursday, September 8th, the same time for part 3 in this series. Session 1 will be all about inequality you can't ignore, led by the Chrysalis Initiative. And session 2 will be I Gotcha Sis, led by For the Breast of Us. Please remember to fill out your evaluation. Your input is very important to us. Thank you again, Tiger Lily Foundation and Touch the Black Breast Cancer Alliance for tonight's great program. Keep in touch with us on Facebook, Instagram, and Twitter. And check out TigerLilyFoundation.org and TouchBBCA.org for more information on each of these organizations and their services. See you next week. Have a great evening, everyone.